Good afternoon to everyone. I would like to everyone for this CCR, where Medicine Unit 3 from Department of Medicine presenting CCR today. We are presenting an interesting case from Unit 3. Dr. Nimisha and Dr. Bhavesh will present the case and Dr. Animesh Ray will discuss the case. Thank you. I would like to invite Dr. Nimisha.
Thank you, sir. Respected faculty and residents assembled here today, a very good afternoon to one and all. I am standing before you to present clinical combined rounds on behalf of the Department of Medicine, and our topic today is from lung to kidney and uncommon link. Before I start, I would like to extend my gratitude to respected faculty of Department of Medicine for this wonderful opportunity and for their help and guidance. Here we are presenting case of a 42-year-old male resident of Delhi with no prior comorbidities. He is a known case of severe COVID ARDS who was initially managed in outside hospital where he was intubated and further tracheostomized. He was then referred to AIIMS for further management. He did not have any significant past medical history, and at presentation on general physical examination, he had a saturation of 93% on pressure support ventilation on 10 by 5 pressure support at 50% FiO2. Other vital parameters were normal. On systemic examination, he had bilateral basal creps on respiratory system examination. Other systemic examination were normal. So we have now a 42-year-old male with post-COVID sequelae with type 1 respiratory failure. At presentation, his baseline investigations were normal. TLC was on the higher side. Chest X-ray showed bilateral, peripheral and basal predominant reticular infiltrates. CCT chest was also suggestive of post-COVID fibrotic changes in the form of bilateral multifocal GGOs, reticular opacities and traction bronchiectasis with peripheral and basal predominance. On day 19 of illness, his ABG showed respiratory alkalosis with metabolic compensation on PSP mode with F50% FiO2, PF ratio being 145. His input-output was 1500 above 1300. The treatment that he was receiving was meropenem and vancomycin, methylprednisolone, nintedanib tablet, Pantop, and prophylactic anticoagulation. Between day 19 and day 26 of illness, FiO2 requirement was tapered to 30% and patient was hemodynamically stable. On day 26 of hospital stay, he developed increase in ET secretions with persistent fever spikes and worsening PF ratio. His vital parameters also showed hypotension with tachycardia. ET aspirate samples were sent which grew multi-drug resistant Klebsiella pneumonia sensitive to polymyxin alone, for which the patient was started on injection imipenem, polymyxin B along with nebulization colistin. On day 19 of hospital stay, his fever subsided, meaning that the polymyxin VAP had responded to polymyxin B. However, during bedside rounds, we noticed that uro bag of the patient was almost always full, and we noticed that the patient was producing a significant amount of urine output. On observing the input-output trends, we noticed that on day 31 of illness, his input was 3260 with an output of 4300, meaning that the patient has developed polyuria. Polyuria is defined as a 24-hour urine output of 3 liters or more. We approach polyuria by first measuring urine osmolality. Our goal is to differentiate between solute diuresis and water diuresis. So in our patient, urine osmolality was measured and it came out to be 391, meaning that the patient could be having solute diuresis. Then we went about ruling out the common causes of solute diuresis. The patient did not have hyperglycemia, did not receive mannitol or radio contrast, was not having high urea levels, no recent AKI, and was not on diuretics. So it seems that our patient is having solute diuresis with no evident cause. So we have till now a 42-year-old male with post-COVID sequelae with VAP due to Klebsiella pneumonia and polyuria due to solute diuresis with no evident cause. Other investigations on evaluation showed ABG analysis showing a combined metabolic and respiratory alkalosis on day 31 of illness. Now, this respiratory component could be explained given that the patient is a case of post-COVID sequelae with ventilator-associated pneumonia. But the metabolic component of alkalosis did not fit in. So we decided to approach this step by step. So how to approach metabolic alkalosis? It is important to understand the pathophysiology. It can be because of loss of H plus ions through renal cause or non-renal cause and gain of bicarb through contraction alkalosis or because of exogenous bicarb supplementation. So urinary chloride is an important parameter to differentiate between renal causes and non-renal causes. In our patient, urine spot chloride was measured and it came out to be 121, which is higher than 20, which is the cutoff limit. So patient was having high urinary chloride metabolic alkalosis. That is, the metabolic alkalosis in our patient can be explained by loop or thiazide diuretic use, mineralocorticoid excess, or any congenital tubular defect like Bartter syndrome or Gittelman syndrome. So we have till now a 42-year-old male with post-COVID sequelae with VAP due to Klebsiella pneumonia, polyuria due to solute diuresis with no evident cause, and metabolic alkalosis, which is high urinary chloride alkalosis, which can be explained by diuretic use or congenital tubular defects. Then we noticed that on observing investigations, patient was also developing hypokalemia. So as it can be seen on day 34, the potassium had decreased to 3. So how do we approach hypokalemia? We have to follow a step-by-step approach in which first we have to do a basic history, physical exam and lab test review. So in our patient, so we went about ruling out any causes of low intake and causes of transcellular shift. So after ruling out the above two, we have to look at the urine potassium to see for any renal loss. So after seeing the urine potassium, we use a cutoff of 15 millimoles per gram creatinine to rule out the extrarenal causes and renal causes. So in our patient, we measured the urine spot potassium and we calculated the potassium creatinine ratio and we converted it into milliequivalents per gram creatinine. So it came out to be 20, which is higher than the cutoff limit of 15. That is, in our patient, we can rule out any causes of low intake, any causes of transcellular shift, and since urine potassium was high, we can conclude that the patient was likely having a renal loss of potassium. Now, how do we approach a renal loss of potassium? So, in this case, transtubular potassium gradient is an important parameter. It is a parameter which helps us to gauge the distal potassium secretion in the renal tubules. So, we use a cutoff of 4 to understand if the patient is having a distal potassium secretion. And in a patient of hypokalemia, we expect it to be less than 2, which means there is no increased distal potassium secretion. We should think about any increased tubular flow or osmotic diuresis. So after, if the patient is having a distal potassium secretion, we should look at the volume status of the patient. So if it is high, it means the patient could be having a condition which is leading to excess mineralocorticoid activity in the renal tubules. If it is low or normal, we should look at the acid-base status. If it is in the metabolic acidosis, then we can consider causes like diabetic ketoacidosis or renal tubular acidosis. If the patient is having metabolic alkalosis, we should look at the urine chloride as shown previously to differentiate between the various causes. If the urine chloride is low, it is suggestive of conditions like vomiting and chloride diarrhea. And if it is high, looking at the urine calcium creatinine ratio can help us to differentiate between sodium chloride channel defects like thiazide diuretic use and Gittelman syndrome and sodium potassium chloride channel defects like loop diuretics and Bartter syndrome. So in our patient, we calculated TTKG, it came out to be 10.63, that is, it is high. And we also estimated the urine spot calcium creatinine ratio. So as per this algorithm, since TTKG is high, we can rule out causes of increased tubular flow and osmotic diuresis and can understand the patient is having increased secretion from the distal renal tubules. And since the BP was on the low or normal side, we can rule out causes of mineralocorticoid excess. Since the patient was having metabolic alkalosis, we can rule out causes like DKA and RTA. And since the patient was having high urinary chloride, we can rule out vomiting and chloride diarrhea. Since the calcium creatinine was high, we can rule out thiazide diuretic and Gittelman syndrome and conclude that the patient can be having a sodium potassium chloride channel defect like loop diuretic use or any congenital tubular defect like Bartter syndrome. So we have now a 42-year-old male with post-COVID sequelae with VAB due to Klebsiella pneumonia, polyuria due to solute diuresis of no evident cause, metabolic alkalosis which can be explained by diuretic use or congenital tubular defect, and hypokalemia due to renal loss due to diuretic use or Bartter syndrome. Then we also noticed that the serum magnesium was also heading towards a low decreasing trend and the patient subsequently developed hypomagnesemia on day 34 of illness. So how do we approach hypomagnesemia? So first of all, we should look for causes which can lead to decreased intake or absorption, and we should look for increased loss through skin, renal and GI losses, and we should also look for any redistribution. So in our patient, since patient was not a chronic alcoholic, did not have any TPN use and was not on chronic PPIs, we can rule out any causes of decreased intake or absorption. And since the patient was not having any refeeding syndrome, no hungry bone syndrome or underlying pancreatitis, we can rule out any causes of redistribution. So we concluded that the patient is having increased magnesium loss. Since the patient did not have any extensive burns or skin injuries, we can rule out any loss from the skin. And since the patient was not having any chronic diarrhea, we can rule out any GI loss. So it seems as though the patient is having increased renal loss, which can be explained by diuretic use or any genetic tubular defect. So we have a patient with polyuria due to solute diuresis of no evident cause, metabolic alkalosis likely due to diuretic use or any tubular defect, hypokalemia due to renal loss which can be explained by diuretic use or Bartter syndrome, and hypomagnesemia which can also be explained by renal loss due to diuretic use or tubular defect. So looking at all the four metabolic abnormalities, we notice that the common link in all four of them is loop diuretic use or Bartter syndrome. However, our patient was not on any loop diuretics and baseline investigations and history were normal, ruling out any congenital tubular defect like Bartter's. So on resolution of ventilator associated pneumonia, we discontinued polymyxin B. Then we noticed that all the metabolic abnormalities resolved after 6 days of discontinuation of poly B. As can be seen in this graph, the urine output which had increased to polyuria was on a decreasing trend on discontinuation of poly B. The serum potassium also improved. The bicarb levels decreased, suggesting the metabolic alkalosis had also resolved, and the magnesium was also improving. The patient developed new onset fever spikes on day 44 of illness, and the X-ray chest showed a new patch, suggesting that the patient may have developed a new onset hospital acquired pneumonia. And given our local antibiotic susceptibility data, we added polymyxin B again. So as per this table, we can see that on day 9 of polymyxin B, the patient's bicarb was on an increasing trend. Urine output had again increased to polyuria, potassium had decreased to hypokalemia, and the magnesium had also decreased. So it seems as though the re-exposure of polymyxin B is leading to recurrence of the adverse event. So looking at the whole picture, we can see in this graph that the urine output had increased on day 5 of the first edition of poly B, improved on discontinuation of poly B, and again it started increasing on restarting poly B. Similarly, magnesium also had improved on discontinuation of poly B and again decreased on restarting poly B. Potassium also followed the same trend, and the bicarb levels also increased on poly B and improved on stopping poly B. So looking at the whole picture, we noticed a definite temporal correlation of polymyxin with the unexplained events. So we suspected that the patient could be developing the metabolic abnormalities due to poly B. And since looking at the whole four metabolic abnormalities, it was suggestive of a Bartter-like phenotype. Then we considered maybe the patient is developing acquired Bartter syndrome. Then on literature review, we saw that drugs are the most commonly implicated cause for acquired Bartter syndrome. Previous case studies have shown that Bartter-like phenotype has developed due to colistin use, gentamicin, netilmicin, and capreomycin use. However, a patient was not on any of these drugs. Then we thought that maybe the patient was developing a previously unreported adverse drug reaction. So, what is an adverse drug reaction? It is defined by WHO as any noxious, unintended, and undesired effect of a drug which occurs at doses used in humans for prophylaxis, diagnosis, or therapy. And causality assessment is the method by which we evaluate the association between the drug and the suspected reaction. And this assessment can be undertaken by clinicians as well. So how do we do causality assessment? Various algorithms have been designed for the same. And one of the most commonly used algorithm is the Naranjo's algorithm. So we decided to apply this algorithm in proving causality of polymyxin B in this case of acquired Bartter-like syndrome. So this is a questionnaire based algorithm. So as per this algorithm, since the adverse event appeared after the drug was administered, we gave a score of 2. And the adverse event improved when the drug was discontinued. So we gave a score of 1. The adverse event also reappeared when the drug was re-administered. So we gave a score of 2. Other alternative causes were ruled out and the adverse event was definitely confirmed by objective evidence. So total score in this case came to be 8. Now how do we interpret this score? So we use various score categories to assign causality, and in this case, since the score came out to be 8, we can assign a causality of probable causality. That means our patient is likely having polymyxin B induced acquired Bartter syndrome. So my final diagnosis in this case is we have a 42-year-old male with post-COVID sequelae with ventilator associated pneumonia with polymyxin B induced acquired Bartter syndrome. Now I would like to call upon senior resident Dr. Bhavesh to continue the discussion. Thank you.
Thank you, Nimisha. So now let us review some literature and answer the important questions raised by this case. The first question is, did the patient have polyuria? So polyuria is defined when an urine output is more than 3 liters per day in adults, and in children a urine output of more than 2 liters per meter square per day is considered to be polyuria. Polyuria is uncommon in ICU setting and reported incidence varies from 1 to 3%. Unlike oliguria and anuria, which is much more common in ICU, oliguria is seen in up to 30 to 50% of patients and anuria is seen in 10 to 35% of patients in ICU. Polyuria can be due to water diuresis or solute diuresis. However, solute diuresis is much more common in ICU. Whenever polyuria occurs in ICU, cause is often apparent. The usual causes include loop diuretic use, resolving acute kidney injury, excessive IV fluids, and drugs like mannitol. Very, very rarely, Bartter syndrome can be a cause of polyuria. So why is our patient not having genetic Bartter syndrome? So Bartter syndrome is an inherited hypokalemic salt losing tubulopathy which is inherited as an autosomal recessive disorder, and it is estimated to affect 1 in 1 million population. So it's a very rare disorder. And the main pathophysiology is defective sodium potassium 2 chloride co-transporter in the thick ascending limb of loop of Henle. And based on the gene that is affected in patients with Bartter syndrome, it is divided into 5 types. So as we saw, the main pathogenesis was dysfunction of sodium potassium 2 chloride channel in the thick ascending limb of loop of Henle. As a result, the sodium, potassium and chloride is not reabsorbed in the thick ascending limb of loop of Henle, causing increased distal delivery and increased loss of sodium and potassium and chloride from the renal tubules. Along with sodium, water is also excreted, leading to volume depletion and activation of renin-angiotensin aldosterone mechanism, causing secondary hyperaldosteronism. So as a result of hyperaldosteronism, there is an excessive exchange of sodium with potassium and hydrogen ions in the distal tubules, causing hypokalemia and metabolic alkalosis. Also, the sodium, potassium and chloride that is reabsorbed in the thick ascending limb of loop of Henle is essential for generating an electrochemical gradient for passive reabsorption of calcium and magnesium, which does not occur in patients with Bartter syndrome, leading to increased urinary loss of calcium and magnesium. This gives the characteristic hypokalemia, metabolic alkalosis, hypomagnesemia, and hypercalciuria in patients with Bartter syndrome. As we saw previously, based on the genetic defect, it is divided into 5 types, and it is important to recognize that most types of Bartter syndrome present antenatally with polyhydramnios, prematurity, and neonatal hypovolemia. However, Bartter syndrome type 3 can present postnatally, but even then it will present by 5 years of age. So it is very unlikely that our patient could be having genetic Bartter syndrome. Also, hypokalemia is almost always seen in patients with Bartter syndrome, which was not there previously when the patient presented to us. So we concluded that our patient could not be having Bartter syndrome, but must be having some disorder which is mimicking Bartter syndrome. So on review of literature, we found that there is a syndrome called East syndrome, which is because of mutation in KCNJ10 gene, and it presents with epilepsy, ataxia, sensory neural hearing loss, and tubulopathy. However, it also presents in infancy and is unlikely in our patient. The only other alternative that remained was acquired Bartter syndrome. So on review of literature, we found that there have been 14 case reports of acquired Bartter syndrome, most commonly due to drugs. There are 8 case reports of drug-induced Bartter syndrome, most commonly by polypeptide antibiotic colistin and aminoglycoside antibiotics. The other causes of acquired Bartter syndrome include sarcoidosis, Sjogren's syndrome, Hashimoto's thyroiditis. In 2 case reports, the cause of acquired Bartter syndrome could not be identified. These references highlight the case reports, and one of the case report is from our own institute. So we saw that there have been 4 case reports of colistin-induced Bartter-like syndrome, and the mean duration of onset of Bartter-like syndrome after starting colistin was 8.5 days, and the mean duration of resolution of Bartter-like syndrome after stopping colistin was 4.75 days. In our patient, Bartter-like syndrome started on day 4 after starting polymyxin B nebulized colistin. So we have seen only colistin-induced Bartter-like syndrome. Can polymyxin B also lead to Bartter-like syndrome? That is to be known. So polymyxins are a group of polypeptide antibiotics that include polymyxin A, B, C, D, etc. It was first developed in 1950s. However, it was not used frequently because of the nephrotoxicity and neurotoxicity associated with polymyxins. However, due to emergence of multi-drug resistant organisms, we are increasingly using polypeptide antibiotics now. The 2 polymyxins that are used clinically are polymyxin B and polymyxin E, which is popularly known as colistin. It is important to recognize that colistin and polymyxin differ by just one amino acid. Polymyxin B has phenylalanine, while colistin has leucine here. The important difference is in the way it is administered. Polymyxin B is administered as an active drug, while colistin is administered in it as a prodrug called colistin methane sulfonate. So in patients with normal renal function, approximately 1/3 of colistin methane sulfonate is converted to its active component colistin, and the remaining 2/3 is excreted in the urine. However, polymyxin B is minimally excreted in urine. The urinary concentration is just 1 to 4%. The difference here lies in that polymyxin B is easily filtered at the glomerulus. However, it is rapidly reabsorbed by the renal tubules. So it is reabsorbed by the renal tubules, leading to high exposure of renal tubules to the polymyxin B and associated tubulopathy. Both colistin and polymyxin B are associated with nephrotoxicity. However, recent literature suggests that colistin is much more nephrotoxic than polymyxin B. Our patient was also on nebulized colistin. Can nebulized colistin be responsible for acquired Bartter syndrome in our patient? So Yapa et al. Found that systemic colistin levels after nebulization of the colistin was below the quantification threshold. Similarly, Sophie et al. Also noticed that after repeated nebulization of colistin, colistin concentration was very low in plasma, indicating that not a lot of colistin is absorbed systemically and would not likely be responsible for development of acquired Bartter syndrome in our patient. So how do we treat acquired Bartter syndrome? The mainstay of therapy for acquired Bartter syndrome is discontinuation of the offending drug and replacing it with an alternative drug, and also correction of fluid and electrolyte disturbances. However, it is not always possible to replace the offending drug, as in our case. Our patient was suffering from carbapenem resistant Klebsiella or carbapenem resistant Enterobacteriaceae, and the common mechanism responsible for carbapenem resistance include carbapenemase enzyme production. The carbapenemase enzymes are classified into class A, class B, and class D in Ambler classification, and the most common enzymes being KPC, NDM, and OXA48. In India, NDM is the most common cause of carbapenem resistance in Klebsiella. So KPC and OXA48 can be inhibited by avibactam, and we can target KPC and OXA48 by avibactam. However, NDM, which is the most common mechanism by which carbapenem resistance is acquired by Klebsiella, is resistant to avibactam. In such cases, we need to add aztreonam to inhibit NDM. So, ceftazidime avibactam combined with aztreonam is an excellent combination for carbapenem resistant Enterobacteriaceae, and the other alternatives being meropenem, verbactam, imipenem, cilastatin, rilabactam, and cefiderocol, depending on the mechanism responsible for carbapenem resistance. However, these are not readily available, and in our patient, we had to continue polymyxin B despite the adverse event. I would like to conclude by saying that hypokalemia and metabolic alkalosis are common problems in ICU patients with multiple possible causes. Polyuria with characteristic electrolyte abnormalities, the chloride unresponsive metabolic alkalosis, hypokalemia, hypomagnesemia, and hypercalciuria is usually seen in patients who are on loop diuretics. However, rarely it could represent acquired Bartter syndrome. Drugs are the most common cause of acquired Bartter syndrome, with polymyxins and aminoglycosides being the common agents. Discontinuation of the offending drug and correction of fluid and electrolyte disturbances are the cornerstone of treatment for acquired Bartter syndrome. Thank you. Now I would like to request our faculty, Dr. Animesh Ray sir, to give his comments. Thank you.
Right. Yeah. Thank you. Thank you so much, Nimisha and Bhavesh, for the presentation. So I think we are 3-4 minutes. So what I wanted to say about this case was the reason why we wanted to present this case to this August gathering was obviously one was a series of conditions: hypokalemia, polyuria, metabolic alkalosis, which was happening together in a critically ill patient. So initially we were not sure whether they are related, whether they are unrelated, until we kind of chanced upon polymyxin B. So that was, I think, an important point regarding this case. Second was, when we are dealing with a particular condition, say infectious condition, it's very easy to lose track of, the course of the patient when the patient is not responding. For example, if the patient is having, say, VAP, patient is not responding, deteriorating, we think it must be related to VAP. But in this case, it was not related to VAP. It was rather an agent which was causing all the damage. So, that involved some bit of changing of the mental track, the track of thinking, which I think, we did to an extent. What was also important was that when you base your diagnosis on something which is partially reported or never reported, as in this case, polymyxin B has never been reported, you're always on shaky foundation. You're never sure whether you're right or you're missing something. So what really helped us in this case was following the algorithms, as mentioned in Harrison up to date. We followed the algorithm: hypokalemia, metabolic alkalosis, hypomagnesemia, and they seem to suggest that these diuretic use or Bartter syndrome, they are the culprit conditions. But even then, this was a dead end, because nowhere in Harrison it's written that it can be a Bartter like syndrome, it can be an acquired Bartter syndrome. So it was an improvisation of sort. And secondly, what also helped us was a lot of intra-team discussion, to be sure that we are all thinking in the same line. We are sure that all we need to do is discontinue the drug and conservatively manage the patient by replenishing all the electrolytes. So I think that really helped, and it is because of that probably that the patient had a favorable outcome. We could discharge the patient, and the patient is doing fine now. So with this, I would like to invite Professor Sinha for his comments.
Thank you very much. I think it was excellent presentation. We have 2-3 minutes if you have any question or comments.
Dr. Naval sir, what if you would remember, like, while unit 2, he was admitted under us, and probably the patient had come to us through your reference.
Dr. Noel would like to comment any?
I think it is very well presented, and this was a challenge. This patient was referred to us from another hospital, and because this patient was not being able to be weaned off a ventilator, and he went through multiple problems, and he stayed with us for quite some time. He developed this problem, hospital acquired pneumonia, but it was gratifying that this patient walked back home. Now he's doing very well.
Thank you. Any other question? So if there is no question, I would like to thanks and conclude here. Thank you.
Good afternoon, everybody. So from surgery unit 3, we've got an interesting case of a 52-year-old physiotherapist who came with us with some complaints which posed with threw us with some diagnostic challenges and a lot of therapeutic challenges. So to take you through the journey of this lady, I'll request Dr. Sarvesh and Dr. Joyner as junior and senior resident respectively to start the CCR.
Good afternoon, everyone. I will be welcome all you to the clinical combined rounds. We will be presenting a challenging case whose title is "Don't Bite More Than You Can Chew." Presenting you a case of 52-year-old lady who was a resident of Pune and a physiotherapist by occupation. She presented a complaint of dysphagia for 6 months, which was gradually progressive, more for solids, and was associated with retrosternal pain while swallowing. She has a significant history of loss of weight of around 12 kgs over past 6 months. There was no history of anorexia, nausea, vomiting, voice change, cough, or regurgitation. With this, we are thinking on the line of many malignancy, but patient gave a history of dislodged denture, which she accidentally swallowed 1 year back. She was investigated in the healthcare facility outside, where a radiograph was done and which shows no abnormalities. And she was reassured that she must have passed the denture during her bowel movements. There was no history of any surgical intervention. General physical examination was unremarkable, except an oral cavity examination shows a missing left lower incisor. Systemic examination was significantly normal. With this clinical history, we have a provisional diagnosis in the order of subcision, like malignancy of esophagus, a impacted foreign body, most likely a dislodged denture, or a motility disorder. With these provisional, on reviewing the previous medical records, there was a history of endoscopy in the outside medical college 2 months back, which shows a white hard foreign body, query denture, 20 centimeter from its incisor, and which was embedded in the esophageal mucosa. Attempted removal was unsuccessful. On these provisional diagnoses, we have a diagnostic plan to do a upper GI endoscopy at AIIMS, followed by a CECT neck and thorax and a barium swallow. Upper GI endoscopy done in the Department of Gastroenterology shows a impacted denture 20 centimeter from the incisor with overlying mucosal proliferation. There was no evidence of any growth. Adult scope was not negotiable beyond the impacted site, so an ultra thin scope was used, and the attempted retrieval was unsuccessful. Now I invite Dr. Ankit from the Department of Radiodiagnosis to discuss the radiological findings.
Good afternoon, everyone. So in the evaluation, first a plain radiograph chest, frontal and lateral view was done to look for any foreign body. However, there was no evidence of any radio-opaque foreign body that could be seen on any of the views. However, we could still see some mild mediastinal widening in the frontal radiograph. It was followed by a barium swallow, which showed a long segment narrowing of the upper thoracic esophagus with proximal dilatation of the esophagus. We could see that there was mild mucosal irregularity in the narrowed part of the esophagus, and there was abrupt transition between the dilated part and the narrowed part of the esophagus. Just proximal to the narrowed part of esophagus, we could also see a wide neck diverticulum with partial retention of the contrast. This was followed by a contrast NCT neck and chest, which showed a circumferential narrowing of the upper as well as lower thoracic esophagus. In this, we could see that there was a circumferential thickening of not only the narrowed part of the esophagus, but also the dilated part of the esophagus. However, again, we could not see any radio-opaque foreign body. The circumferential thickening extended for a length of 5.2 centimeters, extending from the D2 vertebra to just below the carina. However, we did not see any mediastinal lymphadenopathy or any infiltration of the surrounding structures. No tracheoesophageal fistula was also seen. So based upon these imaging features, the long segment involvement, as well as the mucosal irregularity and the abrupt transition between the dilated part of the esophagus as well as the narrowed part of the esophagus, the first possibility we gave was of a malignant stricture. However, since there was history of ingestion of a foreign body, a chronic inflammatory stricture of the thoracic esophagus, secondary to lodgement of the foreign body, was also kept as a possibility. So Dr. Sarvesh will continue with the rest of the discussion.
Thank you, Dr. Ankit. With the clinical, endoscopic, and radiologic finding, we have a final diagnosis of impacted foreign body in the thoracic esophagus with esophageal stricture. Our first possibility was inflammatory because the overlying mucosa was normal, and as the radiological findings suggest a long segment stricture, malignancy was also not ruled out. At this point, we have issues. We have issues and concerns. First was, is there a pre-existing stricture where the denture has been impacted, or the denture impaction has secondarily led to a stricture formation? Possibility of malignancy still persists. As the denture was chronically impacted, we have suspected a difficult removal. With these issues, we have a management plan to first attempt an endoscopic removal of foreign body under general anesthesia in main OT. If unsuccessful, we are ready with a thoracoscopy and esophageal myotomy. As we are suspecting a difficult removal, we will also ready with a esophageal thoracotomy and, if needed, esophageal resection with a gastric conduit. Dr. Deepak Gujjar and team of Department of Gastrology performed endoscopy. Initially, a denture removal was attempted using a snare, which was unsuccessful. Then a rigid Jackson forceps were used for the retrieval of the denture, which too was unsuccessful. And then a holmium laser was used to break the denture in pieces and to remove it, but it was causing the mucosal injury, so the procedure was abandoned. So now we proceeded with the thoracoscopy and esophageal myotomy. Patient was kept in left semi-prone position, and one 12 mm camera port and two 5 mm working port were placed. On entering the right hemithorax, azygos was identified, ligated and divided to expose the esophagus. Upper and mid esophagus was grossly dilated with dense periesophageal adhesions. Myotomy was done using harmonic scalpel. As you can see here, there was severely thickened esophageal mucosa. Then a myotomy was extended using L-hook, but we are not able to enter the lumen. So a intra-op endoscopy was done to confirm the site of dissection, but still we are not able to satisfactorily identify the denture and remove it. So a BATS was converted to open thoracotomy. Right posterior thoracotomy was done. Denture was densely adhered to the thickened esophageal wall. Myotomy length was increased and denture was successfully removed. However, there was severely thickened esophageal wall and mucosa was unhealthy. A plan of esophagectomy was made. Esophagectomy was completed and the upper esophagus, which was densely adhered, was kept left in situ. A gastric conduit was made and anastomosis was done with the cervical esophagus. Intra-op guidance was provided by Professor N.R. Das, Department of GI Surgery. This is a schematic diagram showing the same. This is the level of stricture and the level of denture impaction. This part, the upper cervical part, was densely adhered with dense periesophageal adhesions. This is the level of transection at the level of carina. We have resected the distal esophagus with a sleeve of stomach, and a gastric conduit was made based on the right gastroepiploic apedicle. This gastric conduit was then delivered through the retrosternal tunnel and was anastomosed with the cervical esophagus in a single layer anastomosis. So this was the specimen which we have retrieved. This is the tooth part, and these are the clasps which are used, which have helped in the support and have fixed the denture in place. On histopathology, there was a mucosal ulcer with some mucosal fibrosis. There was hyperplastic esophageal mucosa and microabscesses. However, there were no evidence of dysplasia or malignancy. Post-operatively, patient was extubated on table. Nasogenital fees was started on post-op day 5. A routine gastrography was done on post-operative day 7, which shows a cervical leak, which was managed conservatively by opening the cervical wound and daily dressing. Patient was allowed oral sips on post-operative day 16 and was discharged on post-operative 19 with oral and NJ feeds. On post-operative 33, patient was taking full oral diet and nasojejunal tube was removed. Follow-up at 4 weeks, patient was symptomatically relieved and wound healed well. Now I invite Dr. Joyner to take us through the discussion.
Thank you, Sarvesh. The discussion part. Foreign body in esophagus as such is quite common in pediatric population. In adults, it's quite uncommon. However, psychiatric people or prisoners people who are alcoholic, and people who suffer from epilepsy have higher chance of having a foreign body impacted in the esophagus. When a foreign body is ingested, more than 80% of the time it passes through the gastrointestinal tract uneventfully. 10 to 20% of the time they might require a non-operative or an endoscopic intervention. Only less than 3% of the time people need surgery. Esophagus as such is a hollow muscular tube with peristalsis. So we expect any foreign body which enters in it to pass through uneventfully in the gastrointestinal tract. However, there are certain natural constrictions at the level of cricopharynx at the point where the left main bronchus crosses the esophagus and the arch of aorta or the gastroesophageal junction. So at these constrictions, or due to some pathology, if there is any constriction, the foreign body can get impacted. Elderly population have a higher chance of a foreign body ingestion because of their poor sensitivity and poor laryngomotor complex reflexes and the use of denture in that age group of population. The type of foreign bodies, button batteries, coins and footballers are the usual type of foreign bodies that are found in children, and in adults it's usually meat, fish bones, footballers or the dentures. Coming to dentures as such, dentures contribute to 0.4 to 17.6% of the foreign body that is ingested. Previously, dentures were made of metals or other radio-opaque materials or acrylic resins. Currently, they are made of PMMA, polymethyl methacrylate. Those are plastics. Those are inert. They are very comfortable to wear and they are cheap. But the thing is, like, they come with the drawback that they are radiolucent, and hence once it is impacted, it's almost impossible to diagnose with a radiograph. And again, certain dentures have unyielding edges and metal appendages that can lead on to some perforation and cause devastating complications. And when a patient gives a history and comes and present to us, they might be asymptomatic. They might present with symptoms. With symptoms, it is most commonly dysphagia, odynophagia or retrosternal pain, or sometimes they can straight away land up with complications like a perforation, abscess, mediastinitis, or sometimes even fatal complications like an aortoesophageal fistula. Investigation, we might initially get a radiograph of the neck, chest and even the abdomen depending upon the time of presentation, and it might reveal dentures who have metal components or metal clads. Other might not be visualized, and hence we must be aware that the current processes, dental process that they use are usually not visualized in a routine radiograph. Upper G endoscopy is the first investigation of choice, and it has both diagnostic and therapeutic potential. It can also look at the mucosa and we can rule out if there is any malignancy. CECT, they can identify complications, they can also guide for the treatment, and they are very sensitive and specific. However, we might not find direct evidence of a impacted denture in a CECT. However, there are indirect signs which might say, yeah, with the history also, we can suggest that, yeah, the denture has been lodged over here. Similarly, even in our case, even with the CECT, we were not able to surely say that there is an impacted denture in the esophagus. So whenever a patient comes with a history of denture ingestion, you go in with the X-ray radiograph. If the denture is visualized, you go ahead with a rigid esophagoscopy. When the denture is not visualized, again we have three scenarios. The patient is symptomatic, the patient is asymptomatic. If the patient is symptomatic, again you go in directly with the rigid esophagoscopy. If the patient is asymptomatic, you get a CT neck and thorax. So if it is not visualized, it means it has passed lower down the GI tract and it might pass uneventfully, and we can observe. But if you are finding signs that it's still impacted in the esophagus, you can go ahead with the rigid esophagoscopy. If the patient presents to you with a sign of complications, then go ahead with the CECT, and depending upon the hemodynamic status of the patient, we can either go ahead with the rigid esophagoscopy or a neck and thorax exploration. Treatment as such, the first important step is to assess the patient and secure the airway. High index of suspicion is needed for an impacted foreign body, and an early upper GI endoscopy is warranted. While doing an upper GI endoscopy, a careful assessment and gentle manipulation is needed to disimpact the denture, as this procedure itself can cause a mucosal injury. And again, time from ingestion and the point where we do the upper GI endoscopy determines the success of the procedure. More than 90% of the time, if the patient presents to us within 24 hours, we might be successful retrieving just with an upper GI endoscopy. Indications of surgery: when there is one or more failed attempts of an endoscopy, or if the patient directly presents to us with complications like perforation, mediastinitis, abscess, or an denture has done an extraluminal migration, or there is impacted denture at the level of an aortic arch. If it is impacted at the level of an aortic arch and we try to disimpact the denture, there are high chances that it can cause injury and it can lead on to an aortoesophageal fistula. And hence an upper GI endoscopy should be done very carefully or better avoided. And for unsuccessful endoscopy, surgical approach is the next best step to treat the patient. Coming to the surgical approach, in an impacted denture, when the endoscopy has failed, there might be two possibilities. Either there might be a cervical impaction or a thoracic impaction. If there is a cervical impaction, you directly go ahead with the cervical esophagotomy. You remove the impacted foreign body, you close primarily or close with the sternocleidomastoid flap. If there is a thoracic impaction and the patient has presented to us early with minimal or no sepsis, VATS is a viable option in these cases. If not, an open thoracotomy can be done. If the VATS or an open thoracotomy, like an esophagotomy, fails, or if the patient presents to us delayed or with signs of local sepsis and necrosis, you can go ahead with an esophagectomy in these cases. And again, this is a case series wherein they have 15 patients where they have successfully removed impacted dentures in the esophagus. So the time of presentation varied from 4 days to 5 years. 7 of the cases were cervical impaction and 8 were thoracic impaction. So in cervical impaction, the time of presentation were 4 days to 2 weeks. But in thoracic impaction, it was 1 week to 5 years. It means like in thoracic impaction, patient might have lesser symptoms, and that is one of the reasons patient present to us late. Even in our case, as if patient was asymptomatic for 6 months, and after that only she landed to us. So whenever we have a thoracic impaction, we might always be a little aware that yeah, still it might be stuck over there, and the patient might present to us late. This is again the most case series that I could find in our literature search assets. So there are totally all these case series are impacted dentures at the level of esophagus. Here you can see like there were total 183 patients. Among this 183 patients, like more than 60% of the time, dentures are impacted at the level of cervical esophagus only. And comparatively, more than 12% of the time, patient presents to the medical healthcare facility directly with complications. And close to 16% of the time, the patient needed surgery. So compared to a routine foreign body, so patient needs surgery less than 3%. But when a denture is impacted, the chance of the patient having a failed endoscopy and needing a surgery increases a lot. And again, the type of surgery as if like even in these cases, there are 5 cases wherein they had to do an esophagectomy, and there are 4 mortalities and significant morbidity also in these cases. And again, this is another literature review of last 20 years. Here you can see there were 49 failed endoscopic removals as such. So in among these 49 cases, 28 were dental processes alone, and 13 times they were not able to know what exactly was the foreign body. So somewhere between 57 to 77%, when there is a failed endoscopy, the reason is because of a dental impaction. And the reason for failure is mostly because it is either caught in the wall because of the rigid clasp, or there is an extraluminal penetration because of the sharp edges that denture possesses. So coming to the GI surgery experience, since Professor Das sir is not here, I would like to take through these slides also. So in the last 10 years in our GI surgery, there have been 14 cases. So in the 14 cases, 1 cervical esophagus impaction, 2 upper third of esophagus, 8 middle third, and 2 lower third, and 1 denture which was removed successfully by endoscopy, but post removal it developed a tracheoesophageal fistula. So you can see the dentures even in this radiographs, whenever they have some metal clips or like metal appendages, then we might be able to find out like exact location of where exactly the denture is impacted. And again, among these cases, there were there were 14 cases in which they were able to successfully extract through VATS, and these are early cases. Here you can see this is an early case wherein a denture is impacted at the level of the mid esophagus, wherein we were able to identify even extraluminally where this exactly is the site of denture impaction, and myotomy is successfully performed, and the foreign body being successfully retracted, and the esophagus being closed primarily. And to conclude, now I would request Dr. Suhani ma'am to further continue the discussion.
So why did we choose this case? So this case was a diagnostic challenge for us. It's something like the chick and the hen. Which was first? The pre-existing stricture led to impaction of the denture, or the denture was actually causing an inflammatory stricture? And then there was also a doubt on the radiology of the possibility of malignancy. However, we kept this lower down because on the endoscopy, the mucosa was, the visualized mucosa was per se normal, and it's unlikely for a malignancy to have a normal mucosa. This was also a therapeutic challenge for us because whenever we do a myotomy, there is some mobilization of the esophagus that is required, even in benign conditions like achalasia. So we go into the thorax from the abdomen for about 5 to 7 centimeters, mobilize the esophagus. But in this case, there was extremely dense adhesions because of the long-standing impaction of foreign bodies. Some microperforations might have happened, and there was dense periesophagitis, because of which the mobilization of esophagus was nearly impossible during VATS. And the impaction happened at high up, which is a very critical site because of the important great vessels of the thorax and the carina that is present adjacent to it. So, to conclude, dentures may not always be radio opaque, and the newer ones are radiolucent. And since there is a high risk of impaction with dentures, we need to have a high clinical suspicion even amongst the clinicians. This leads to an early diagnosis, and rigid endoscopy may be successful if attempted within the first 24 to 48 hours, especially. Failed endoscopic attempts should prompt surgical intervention. And VATS is a viable option, but in uncomplicated cases presenting early where the adhesions and the periesophagitis and strictures don't form, thoracotomy is inevitable in long-standing impacted and complicated scenarios. So with this, I'll conclude the CCR. Dr. Das, sir, you'll like to present your slides. He had already shown it once. Yes, sir, we've discussed in case you...
Sorry, extremely. I just got up, stock up in OT. We have managed total 16 cases of foreign bodies. Most of these, and 14 of them are dentures. The dentures come to us in an impacted state. And outside, they're mostly managed by endoscopy. If they are mobile, the endoscopy should remove it. If they are not mobile, it's extremely difficult to remove them. We have tried, persisted, insisted, and tried to remove one by endoscopy, and we ended up in a tracheoesophageal fistula. So after that, if it is really stuck, the endoscopists, they really stop there and allow us. And 3 were impacted here. If it is up to the C8 level, easily you can open the neck and take them out and close the esophagus with a drain. The one which was stuck in the down part of the esophagus, abdomen was opened and it was taken out through the stomach route. The problem lies in the middle part, wherein if the patient knows when he has taken the denture, it becomes easy to take them out in 48, 72 hours. Sometimes they are 4 months, 6 months. One case, the ENT people, if they are there, they will remember the patient came after 1 year with an abscess here. No history, nothing. And it was open and they found the denture coming out. That can also occur. So those 8 cases we managed thoracoscopic, through thoracic route surgery. 4 of them were earlier on managed open. 4 we managed laparoscopically, and all of them we could manage successfully. So most of them would come to us with this type of chest X-ray with wide mediastinum. Nowadays we have intelligent dentures. We won't find them on X-ray. There we need the help of endoscopist, and they could. This case, all imaging multiple times said that there was no chance of it. Denture couldn't be found. But endoscopy said they are there. So we thought the denture was there. We proceeded like that. They can come to us with localized perforation, mild stick of contrast, and even going to the costophrenic angle. And or they would come with thickening of the esophagus. The denture may be visible. This was earlier on. And this was with a content perforation. And this is where the thickening of the esophagus is there. Where is that? Okay. This is the second of the case wherein we get a laparoscopic view of the chest. It's very clearly seen that there is a swelling with edema of the middle part of the esophagus. You open that one, you find the denture. This was this denture actually. You can retrieve and then stitch it and cover it with a part of the pleura to give it to strengthen it. And this is what in another case which came out through a small hole. Ultimately you have 3 or 4 holes in the chest, and that's all. Otherwise you have a huge thoracotomy incision. And this can be bad like this. The tissue may not be visible very clearly. We removed it, freshened the margins by cutting and closed it. Or they can be with a hole inside the chest cavity, and you can still do it primarily with a closure with pleural patch and with your drain. So, this case, as they have said, we first tried laparoscopically, and we thought that there was a denture there. We opened, we didn't find, because it was malignancy. We didn't want to. It was not appearing like a tumor, so we little bit persisted in trying to open it and take it out. But with that suspicion, we didn't go much above. We terminated that, opened the chest, took out the denture, and then completed with it esophagectomy. So that was, and the literature is very limited on this, mostly case series, but laparoscopic removal, possibly Palanivalu is the only person who has described this in 2 cases. And we had a small survey along with the gastromedicine people. We found that in Indian scenario, the chance of getting a denture ingested without knowing is much high. Maybe that is because of the picture which I showed, that they used to drink water like this, and the elderly people, they did not know whether it's slipping and going in, and then later on they may not discover that this was there or not there. So we strongly suggest that all the dental people who are putting these dentures, they should counsel the patient to check it every night while they are sleeping and getting up in the morning. That's what we are suggesting. Thank you.
Thank you, sir. We'll now open the house for discussion. Okay.
They can recommend that you should put a radiobase material.
So it is a recommendation, but you have to recommend, you have to keep in touch with a huge people, huge number of people to say
Dr. Das, thank you very much. Excellent case. How many cases have we done surgery?
12 cases.
Okay.
Done surgically, 4 by laparoscopy.
Yeah.
And this one is the only one wherein we have to go for a complete esophageal.
And how much size have to be there for impaction in the esophagus? Like if single tooth is there, so it will pass through.
This was the single tooth.
Yeah.
One of our case was single. Three teeth I showed, and one we were really having problem wherein those hooks, the metallic hooks were there earlier on. Those are very difficult. We have done. Yes.
So when they try to dislodge it intraoperatively endoscopically, he was bleeding. They had to open and then they had to repair that.
The outtake is described. Yes.
Thank you.
In fact, at that level, they say that even a endoscopy should be very, very carefully done or avoided, because the chances of
They could save the patient. That's it.
So thank you for the nice presentation. I had a very small question. I mean, the way I understood it, that impacted foreign bodies, thoracic, they should also be approached by surgery, primarily surgery, right?
not primarily surgery. The first approach, if the patient presents early, reliable history, is endoscopy. If the endoscopy
If it is impacted.
if it is impacted and the endoscopic, the first attempt fails, then surgery is the preferred modality of treatment.
We had 16 cases total of foreign bodies. Out of this, these are 12. If it is impacted foreign denture, then yes, 25 chance of literature says that you can cause damage. And 4 cases we had 2 fish bones, two meat bones, 1 chicken bone, 1 mango seed. And this mango seed we have published. This one you can still attempt, take it up. But denture, because of the hooks and the points.
Right. So both these endoscopic attempts, outside and inside, they were by rigid
Actually, the
endoscope, or
outside attempt was done in another medical college, and we are not very reliable on that document. So in here, it was attempted by Dr. Deepa Gunjan. He's here, and the first attempt failed, and the second, since esophageectomy is a major morbid procedure, we plan to do it in our main OT, the video that we had shown. It was done at the time when the esophagectomy and the esophageal myotomy was planned. So it was planned as if in case this attempt fails or in case there's a mucosal perforation, esophageal perforation, then the patient, we have a consent and the OR ready for the surgery. Dr. Deepa Gunjan, you'd like to add anything?
Denture is very masquerading. I think I remember distinctly 4 or 5 cases. In one case, I remember patient presented with tracheostomal fistula after 5 years of, and this patient has multiple dilatation because of esophageal stricture. On endoscopy also, they are not able to detect the patient has a denture infection. So any patient who has denture and patient has esophageal stricture or dysphagia, even after years, I think clinician must suspect the denture has impacted into the esophagus. That's a very important point, because you see in literature also the duration of presentation in 5 years, 6 years. That's very long duration.
In fact, since there are no recommendations per se, if a patient has a reliable history, but the patient is asymptomatic, an endoscopy is still mandated to rule out that there is a foreign body in the thoracic esophagus. Chumbar sir? सर को माइक दे दो माइक दे दो सर
thoracotomy and removal, and it is the hooks in the dentures, no, that makes life very difficult, even on removal, because they catch the mucosa for free. We have done thoracotomy, and then we had opened up the esophagus to remove this. And the problem with the
yes for 6 months first 6 months she had such mild symptoms that it was only on deep interrogation that she revealed it retrospectively. After 6 months she started having symptoms. The light can be seen, plus it was an endoscope, so when you hit the wall of the esophagus, in this scenario, the light may not be very much visible, but if the esophagus doesn't have so much of periesophagitis and thickening, the light is usually visible. And and लाइट से भी और वो स्कोप का टिप जब हिट करता वॉल को, सो यू सी एन इंडेंटेशन कमिंग इनसाइड. Dr. Krishna, she is there from CDR. Maybe she can give a idea about the.
The part of the normal instruction that we give the patients to put the dentures in the water, but yeah, many a times patients don't, and then they'll end up with these problems. So this was a really enlightening. Uh, sorry, sorry about that. So this was very enlightening presentation, and as Dr. Raj suggested, this is a routine instruction to all our denture patients to remove the dentures at night and put it in water, but many times they don't follow. They keep it in mouth and then they swallow, and these kind of things happen. PMMA, yes, it's the routine thing, dental material that we use. Another thing that will not be visible on X-ray will be porcelain. That is the fixed teeth or the single 1 or 2 unit bridges that we make. That's another one that can have similar kind of thing. But yeah, so metal clasps, they are usually not used. Cast partial denture or the whole metal denture, that is also not in use nowadays. But PMMA and porcelain, they both can present such problems. So thank you for presentation.
Can you, sorry, are we radioactive, radiolucent material
Yeah, so
like
with
we
our
use in
city,
gauze pieces and mops,
got it.
just
So
incorporated into that? So it's really difficult.
this is very good input, and I'll definitely talk to the second floor people in CDR, my colleagues. So I'll talk to them. Yeah, Dr. Veena Jain. Yeah, I'll definitely. With the prosthodontics team, I'll definitely share that. So sure, thank you.
So
प्लांट को आई थिंक मेटालिक होते हैं
हाँ वो metallic होते हैं उस The another thing is bridge, porcelain made bridge. That's what I said. Other than PMMA, porcelain tooth also can be this pose this problem. Yeah.
they cause lot of कोई aorta फट गया उसको
Professor Raju from Department of Radio Diagnosis helped us with the radiology. Any comments or inputs, sir?
Mike, it's just amazing how crystal clear things appear when they are seen in hindsight, in retrospect. This case was a challenge because that stricture looked malignant. You know, at the proximal end of the stricture, Dr. Dash was so concerned, Dr. Rajendra was so concerned. They kept asking us, can this be a malignancy? And surely it can be a malignancy because that stricture morphology was very closely mimicking a malignancy. When you have proximal shouldering, you know, because the malignancy could be causing a narrowing because of which the denture is impacted there. So that possibility, I think we cannot discount that in the in real world, at least it was a big challenge to try and say that this was not a malignancy.
There are two things to it. Either it's a malignancy per se, wherein it has got stuck, or a change later on when it is 1 year old. But we, even if we knew that this is a malignancy, we would have done the same thing,
Right?
Because you don't know while extirpating the esophagus,
Absolutely.
what is the status
I
of the foreign
understand.
body. That is one.
Yeah.
If there are no more comments, I thank everybody. Thank you.